Okay, we're back again. Phys and histo. 9:15. Okay, so this is near the start of respiratory physiology. Dogs, their normal respiratory rate is 20 breaths per minute. When a dog is panting, it's about 10 times that. We don't pant. Humans don't pant. We just breathe like heavier and somewhat faster. Very similar to a horse, actually. Horses do something similar to that. But dogs and I think cats do the panting thing. Partly because of, and I'll talk about this later, partly because of thermoregulation, but also because of, well, I think it's mostly for thermoregulation. And that's the thing. Horses can sweat. Humans can sweat. Dogs and cats can only sweat on their paws. And very, very little can they sweat. Anyway, so what the dog is doing, is reducing the tidal volume. So that's the amount of air taken in, but they breathe quicker. So they're going shallow, quick breaths. Shallow meaning they breathe in less. And mostly for thermoregulation, I would say. Oxygen bound to hemoglobin does not participate in cellular metabolism. I've just got random facts written down here. Oxygen loses affinity to hemoglobin in high temperature, high CO2, and low pH. So if you've got a situation that's low temperature, low CO2, and high pH, you'd have more oxygen affinity, I think. I need to go over that a little bit more. The more hotter a tissue is, you can assume that it's got a very large metabolic rate, that it needs more oxygen. How you doing, Big Lawn? How you doing today? In the lungs, we exhale CO2, we cool the blood, and we decrease pH. Again, because that's the thermoregulation component. We're cooling the blood because we're inhaling air that's most often than not cooler than our body temperature. And the decrease of pH is caused by the CO2 being produced. And so we need to exhale that CO2. Too much excess CO2 can be acidotic, which means can cause acidosis. That's good, Big Lawn. I'm glad you're doing well. Yeah. Hemoglobin picks up even more oxygen because affinity is increased in the lungs than the oxygen is dropped off in the tissues. So like if you've got more CO2, that hemoglobin it has a higher affinity for oxygen, I think. There was an example of a dog. They were wanting to see how long it would take, or they wanted to see the limit for a dog running on a treadmill in a environment that had low oxygen, like high atmospheric environments, for example. Like, think you're on an airplane or you're on a helicopter, and the oxygen decreases because you're at such a high altitude. Well, what about if a dog's doing it? So they tested that in like a hyperbaric chamber, I don't know, something to decrease the oxygen in the chamber. And the dog actually just kept going. But then they looked at the dog and they're like, this dog's turning blue. Yeah, the dog was turning blue, but dogs are so much more efficient in their respiratory tract than we are. They just, like, their anatomy just finds a way to shunt all the oxygen to the tissues that need it at that point, and then the ones that don't need it appear blue. It's not necessarily a bad thing, it's just they've got less oxygen than what is normal to us, like what normal to what we usually see. And so we're like, oh, that dog's blue, that's not normal. But yeah, and the dog was fine. Dog didn't have a single trouble. Okay, next we have the Bohr effect, Bohr. What this does is it's a shift of the oxygen to hemoglobin curve to increase or decrease affinity of binding. If you shift it to the right, that's a decrease in affinity. You shift it to the left, that's an increase in affinity. And the delivery of oxygen takes advantage of that in the lungs and in tissues. What this entails, there's like a decrease in pH when there's an increase in carbon dioxide, CO2, and an increase in temperature shifts to the right. Conditions found in metabolically active tissue. These are the conditions found in metabolically active tissue, thus allowing increased release of O2 locally. And the reverse occurs in the lung, improving absorption of CO2. Because in the lung, we're trying to release CO2 and absorb O2 so that we can send the O2 to the body and get the CO2 from the body so that we can release CO2 again. You know, it's a cycle. Breathing is a cycle. We don't just stop breathing. The moment we stop breathing, you got problems. Okay. Okay. There's other changes. 2,3-DPG is produced in response to chronic low-grade acidosis. This is when the O2 hemoglobin curve is shifted to the right, and this improves the delivery of oxygen to the tissues. Fetal hemoglobin shifted to the left relative to adult hemoglobin. That's why babies appear to be more red than us, because they've got higher oxygen affinity in their tissues. So their blood is literally more red than ours. That's why babies are so red. Or neonates, you know, less than 4-week-old, newborns, right? I'm pretty sure that's what neonate means. New, neo, born, nate, or natal, right? Okay, the role of blood. Once alveolar diffusion has occurred, blood transports the oxygen to the tissues, right? The RBCs don't use that much oxygen, but they do use some, but minimal amounts. So the oxygen content in the pulmonary vein is basically equal to systemic capillary oxygen content. Once the O2 once gases diffuse in the systemic capillaries, it's the opposite of what happens in the pulmonary capillaries. Soluble oxygen is going to go into the tissue, and then hemoglobin-bound oxygen is released as the partial pressure drops in that tissue. And then the carbon dioxide goes into the blood from the tissue to then go to the lungs, where we exhale it, right, to get rid of the carbon dioxide. Okay, the carbon dioxide is transported in primarily 3 forms in the blood. That's physically dissolved carbon dioxide, so just carbon dioxide by itself. About 5% of blood carbon dioxide is that. And then there's bicarbonate and carbonic acid, which is combined is 90% of that. And then there's carbaminos, which are 5 to 7%. Now the bicarbonate and the carbonic acid is a very unequal ratio. The bicarbonate is like 82% of that, and the carbonic acid is like 8%. So it's much more bicarbonate than it is carbonic acid. What is carbonic acid? It's, well, if you ever had a soda, you know how it bubbles and it tingles as you drink it? Or if you've ever had carbonated water, same deal. That water now contains carbonic acid. That's why it's bubbling. That's why it, tingles as you drink it. That is what that is. It's full of carbonic acid. That is the carbonation in there. But all these things are in equilibrium. Well, the bicarbonate and the carbonic acid is mostly in equilibrium with the water. They kind of just like swap out the bicarbonate and the carbonic acid. Now the CO2 carbon. There's some, like, it sounds like a cat outside. Anyway, the CO2 carbamino content is mostly amino groups on the hemoglobin. That amount is not particularly dependent on the pressure of carbon dioxide. So it's not like within the physiological range of that, but the binding of oxygen to hemoglobin decreases the availability of these amino groups, and that's called the Haldane effect. I don't know if that's how you say that name, but what that does is that essentially delivers about 33% of the exhaled carbon dioxide. Okay, and then something to note is hemoglobin changes color with and without oxygen. With oxygen, it is red, and without, it's more of a purple, more of a blue color. And you can test this yourself. You can look at your veins, and they're blue. You can see they're mostly close to the surface. You can see a lot. There's a couple there. Those are blue. The blood is like blue slash purple. Why? Why is it? Well, because it's taking the carbon dioxide from the tissue back to the heart. And then from there, it'll go to the lungs, right? And it'll get oxygenated again to go back to the tissue. Okay. Bicarbonate and carbonic acid. Like I said, it's actually 96% bicarbonate and 4% carbonic acid, about. And that's dictated by the Henderson-Hasselbalch equation, which I talked about earlier. It's all about you know, I think that equation has to do with partial pressures and equilibriums and stuff. Or it might just be pH equals pKa, that one. Yeah. I don't know. Until I need to know it, I'll learn that later. And I've got a study guide, so I'll just look over that. But the equilibration occurs fastest in erythrocytes in the presence of carbonic anhydrase. So there's a lot of carbon dioxide bound up, and it doesn't freely diffuse, but it's somewhat available. If you were to remove it from the solution, it's just going to get replaced by the carbonate. And you may have experienced this. If you've ever had a can of soda, you know how when you open it, it goes psss, kind of like that. You crack the, that's CO2 gas released. And then the bubbles start to form as the carbonate becomes carbonic acid. And those bubbles are carbon dioxide. It's a reaction with the air. So before you opened the can of soda, I'm pretty sure it was literally like not necessarily, well, it might have been vacuum. It might have been a vacuum in there. I don't know. Or maybe it was just all full of CO2, no oxygen yet. I think that's the more realistic scenario. Okay, Ca is carbonic anhydrase, HCO3 minus is bicarbonate. I actually think that's carbonic acid. I think H2CO3 is bicarbonate. But anyway. Okay, the pulmonary diffusion path. CO2 must travel from plasma and from within red blood cells through the plasma, across the endothelium, through the interstitium, across type 1 alveolocytes, and into the alveoli. And don't forget that CO2 is very soluble. It never is really limited in its diffusion capabilities. However, full equilibration causes conversion of chemical storage forms of CO2 to dissolved CO2. So you could measure the amount of carbon dioxide in the blood, and if you were to say that that was equal to the amount of CO2 in the alveolus, you'd be correct, essentially. But you can't really say the same thing about oxygen. Oxygen is not as soluble as carbon dioxide. Okay, then there's something called VQ matching. This is matching relative areas of ventilation, V, to relative areas of perfusion, Q. And it is the most important factor in ensuring efficient gas exchange. And both active and passive processes help maintain this. Efficient use of alveolar volume is distributed to all of the lung periphery, but it's not homogeneous because many different alveoli have different compliances. For example, bigger alveoli are going to be more compliant. They're going to find it easier to get bigger with that oxygen, whereas smaller alveoli that were already small to begin with, they're going to want to stay that way. And it can become even more heterogeneous with disease, which means I think like the alveoli would be doing stuff that they don't commonly do. It's kind of strange. So to best utilize that alveolar volume, areas of the lung which receive lots of ventilation should receive lots of blood to exchange gases. The tissue compliance of the lung dictates what part can get more, or what part gets more or less air. Somewhat like blowing up a balloon. If you were to stretch the balloon all over before blowing it up, it's easier to blow up. But if you only stretch one part, then you blow up the balloon, only that part that you stretched is going to blow up and it's going to look weird. And you got to keep gravity in mind too. There's parts of the lung that are below the heart, and then there's parts of the lung that are above. So more blood, at least in an animal, is going to be in the ventral part of the lung, vent being on the belly button side, because of gravity. And that would be the posterior part in humans. And then you've got to keep in mind, the guts are pressing on the lungs. So if you've got gastrointestinal problems like gas or bloat or something, those could press on the lungs, decreasing the respiratory capacities, because that decreases the volume, because you can't expand past the point where it hurts, But your body can make the vessels narrower, or what it does is it makes those vessels narrower, and the ventral part decreases flow to them because gravity's already pulling them down. It's already going to be the same as on the top, where the blood vessels are less, or are wider. So adaptation is a thing too. It's going to be equivalent throughout the lung as long as your body has time to adapt to it. But in the case of horses, if you put them on their back, they're just going to eventually become hypoxic because there's just so much gravity, and they weigh so much, their lungs are so heavy too. It's just not, they're just not built that way. And your body can also adapt to build more fibrous tissue. For example, in the dorsal part of the lung in animals, so that it is not as compliant, so that it inflates slower compared to the bottom. Again, that makes sense because the bottom has restricted capillaries and very compliant tissue, so that it inflates the same as the part above the heart that has wider capillaries and more fibrous tissue. But generally, mammalian lungs are quite efficient and little is wasted. But some diseases can cause very critical changes in VQ matching, and that can lead to problems with gas exchange. Again, like I talked about, dorsal recumbency. You flip a horse over, it's going to have trouble breathing. It's going to become hypoxic. Same thing happens in a dog, but not to the same extent because they weigh less. And so whenever you're doing surgery on a dog and you've got them upside down, it's not as bad as compared to when you're doing surgery on a horse and you have them upside down. I'm not even so sure that, I don't know, I've never worked with horses. So I don't know if they do that. They probably do. Okay, and then there's hypoxic pulmonary vasoconstriction. There are chemosensors in the pulmonary precapillaries which detect the pressure of O2 in the region of the alveolus. A low pressure would cause the precapillary sphincters to shut, and that would restrict blood flow to an alveolus presumed to be unventilated. And opposite of that, a high alveolar pressure of oxygen would cause the precapillary vessels to relax, making blood flow easier. And the active component of that is vasodilation. Okay. Pressures. Then there's extremes. Of course, there's always extremes. You take something to high altitude, you can experience pulmonary edema due to a low inspired oxygen. There's not as much oxygen up there. The alveoli are going to have low pressure of oxygen. This is going to cause all the capillaries to constrict, and they can only, you got to keep in mind, they can only constrict so much. And what that does is that causes pulmonary hypertension and edema. Fluid starts to build up. Multiple organ system failure can also occur. That's widespread inappropriate activation of vasodilating messengers like nitric oxide. And this causes extensive capillary dilation, which would literally cause blood to pool in the lungs. Not good. Why? Why do all these happen? Well, there's less oxygen in the alveoli, so capillary blood flow is going to stop, and that's going to cause fluid to come out of the vessels into the tissue because of that pressure gradient, and that's what causes the edema. It's very common in cattle because they're not athletes. They just eat grass, grow big, and get eaten. That's basically their whole goal in life. And there is a genetic component to this, though. Some cattle are genetically acclimated to living in certain altitudes, and this is a I used to know the word for it. This is something that breeders breed for. Just can't remember what it's called anymore. Gradual acclimatization doesn't seem to be as economical. Plus, animals that are geared towards high altitudes are unlikely to do better in low altitudes. There's more than just genetic testing for that as well. You can put a catheter in their pulmonary artery and read the pressure, and a lower pressure would be better in this case for cattle who are going to survive longer or thrive at a higher altitude. So for athletes, there is benefit for altitude training, but there's a huge range of altitude. I mean, you could go to California and then you could go to Colorado. Big difference. And there's also a huge range of athletic performance. If oxygen delivery is the limiting factor, then altitude training may help. But barrel horses, for example, are doing a sprint in like 15, 16, 17, 18 seconds, right? So it's different in that case. They need, they need a lot of oxygen for a short amount of time. And even at low altitudes, some unhealthy animals will start to experience high altitude pulmonary edema because they're just so unhealthy, they have trouble breathing. Anyway, I learned this the other day. The singular for a cow of any breed or gender is bovid. So like if you've got a cow, that cow is a bovid. That bull is a bovid. That steer is a bovid. It doesn't sound as interesting when you're driving past a pasture and you say, hey, look at all those bovids. Or you say, hey, look at all those bovine. You know, versus if you say, hey, look at all those cows. So people know what you're talking about, but at the same time, you're wrong. Because you're saying that that bull is a cow. No, that bull's not a cow. Cows are female, reproducing, or reproducing, sorry, bovids, bovine. So it's not really correct to say that a bull is a cow, if that makes sense. That's just a tangent. Anyway, that's it for physiology and histology. For that, day. That is weird. Now for immunology. Okay. Okay, so it's good to know that selectins cause the rolling phase of a leukocyte to the vein wall, which is weak adhesion. The rolling phase is weak adhesion. And then MHC1 molecules are, they attach to endogenous peptides, and they're found in CD8 cytotoxic T cells. Okay, and that's basically all I'm going to cover for that, because I already took that exam. I don't really need to go over that right now. Now, anatomy. There, yep, okay. Ligaments. Okay, the stifle is the knee joint. Sorry, the knee area. You've got the femur, the thigh bone, tibia and fibula, the crus, bones. And then you've got the patella, which is the kneecap, and the lateral fibula, and the medial fibula, which are the sesamoid bones. Okay, there's menisci. They are anchored to each other. They provide stability to the joint, and they're kind of like cushions, I think, somewhat. But mostly they just connect the bones. There's the cranial meniscotibial ligaments connecting the meniscus to the tibia, menisci. And there's the transverse ligament connecting the two menisci. The cranial cruciate ligament, it's CCL, which is again the human equivalent of the the animal equivalent of the ACL. And there's the caudal cruciate ligament. Then there's the caudal meniscotibial ligaments. Then there's the meniscofemoral ligament. It's all about where they connect, basically. Stifle. Patellar ligament goes from the patella to the tibial tuberosity. Then there's the lateral femoropatellar ligament, medial femoropatellar ligament, lateral collateral ligament, medial collateral ligament. The lateral and the medial femoropatellar ligaments go from the lateral and medial fibula to the patella respectively. Lateral goes to lateral, medial goes to medial. A cranial cruciate rupture is the leading cause of lameness in the dog. Again, that's the ACL in humans. There's many surgeries that can help, that can restore stifle joint stability and reduce the progression of osteoarthritis afterward. But the earlier you do it, the better. And you just need to be a good doctor in order to make sure you're actually, diagnosing the right thing first. There's the drawer sign, which is where you can move the tibia kind of forward, I think. You hold the femur and you apply a firm cranial force to the tibia. It's not going to move in a healthy dog, but in a dog with a CCL rupture, the tibia is going to move forward. There's also tibial thrust. That's where you push up on you flex the hock, and the tibia is going to thrust cranially because the gastrocnemius is going to tense up. Again, cranial cruciate rupture. There's lots of surgeries. There's the tibial plateau leveling operation. You kind of cut through the menisci and the bone. It looks kind of gnarly. And then you just bolt it back together. And I guess what that does is that helps it to not move. And then there's a tibial tuberosity advancement surgery. You just basically correct the angle, or you change the angle of the tibia to the patella from 115 degrees to 90 degrees, and that helps. It offsets the forces in the knee that tend to make it unstable. There's also an extra capsular repair. You drill a hole in the tibia and femur, and then you put a piece of suture through, which basically acts like a ligament itself. It's just like it's almost a ligament replacement. That piece of nylon suture or whatever material it's made of. And then you usually secure it with a special clip instead of a bulky knot, because you've got to keep in mind this is inside of the body cavity at this point. You don't want to cause inflammation in there. And then there's patellar luxation, one of the most common orthopedic conditions in dogs, and it's found in 7% of puppies. It primarily affects small dogs like Boston and Yorkshire Terriers, Chihuahuas, Pomeranians, and Mini Poodles. Medial patellar luxation is more common. This is this one freaks me out, because this one is like the leg, like, oh, It's weird. It kind of the tendon moves, the tendon and the patella move off of the trochlea of the femur. Ugh. And that causes the tibia to kind of turn out. Wow. That's a weird disease. And it looks like it can get even worse. It can like rotate even more. Maybe. Hopefully not. That looks painful. There's also plenty of surgeries to fix that, of course. Yeah. Wow. And I guess I forgot how much there was to learn today. Lots of arteries and nerves. Starting at the abdominal aorta, the first branch is going to be the internal iliac, which branches into the caudal gluteal, which branches into the iliolumbar and the cranial gluteal arteries. Then we've got, after that is the start of the external iliac, which branches into the deep femoral, which then branches into the pudendo-epigastric trunk and the medial circumflex femoral artery. Then after that is the femoral artery, which branches into the lateral circumflex femoral. And then after that is another branch, the superficial circumflex iliac. And then after that is the proximal caudal femoral, then the middle caudal femoral, then the saphenous, and then the descending genicular, and then the distal caudal femoral. After the distal caudal femoral, we've got the popliteal, which has a branch called the caudal tibial. After that branch, it is called the cranial tibial, and then from here on out, it's just new names. Cranial tibial, after that is dorsal pedal, after that is proximal perforating branch 2, after that's deep plantar arch, after that is palmar metatarsal arteries, after that is palmar common digital arteries, and then after that is palmar proper digital arteries. Yep. And then there's the femoral triangle in the thigh region. Very common spot. That's just where all the circulation is located, pretty much. Okay, and then in the canine, the lateral saphenous vein is larger. In a cat, the medial saphenous vein is larger. You got to remember, medial's on the inside, right? Lateral is on the outside, and we're on the pelvic limb. So blood draws, you may have experienced this in a vet clinic, for a cat are usually on, well, at least from what I've seen, are commonly done on the medial saphenous vein. Okay, and then there's the nerves. There's the lumbosacral plexus, and that's from L4 to S3 of the spinal cord. There's all sorts of nerves there. And then there's a femoral nerve. That's an important one. Then there's the obturator and femoral nerves. The obturator nerve is easy. That one goes straight through the obturator foramen, which is the hole in the hip bone. Okay, then there's the gluteal nerves and the sciatic nerve. You've probably heard of the sciatic nerve. The gluteals are obviously in the gluteal region. That kind of helps out. The sciatic nerve is just past that. And it's a pretty thick one, too. You want to avoid the sciatic nerve when you're doing intramuscular injections, because it's around that area. You could hit it when you're sticking a needle into, the gluteus, one of the biggest muscles for the dog. One of the most, from what I've seen, one of the most common for intramuscular injections. Because it's in the back, unlikely that you're going to get bitten when you're in the back, right? It's hard for the dog to turn around. Then there's the tibial and common fibular nerves. Those are found in the crus. Nope, right before the crus. Those are found at the end of the femur, actually. Okay. The superficial gluteal. Okay, so most of the gluteal muscles are supplied by the caudal or the cranial gluteal artery, and they're innervated by the caudal or cranial gluteal nerves. The cranial thigh muscles, like the quadriceps femoris, sartorius, and tensor fascia lata, are supplied by the lateral circumflex femoral artery and innervated by the femoral nerve and the cranial gluteal nerve. Then the medial thigh muscles, like the gracilis, adductor, and pectineus, are supplied by the deep femoral artery and the caudal femoral arteries and innervated by the obturator nerve. The caudal thigh muscles, like the biceps femoris, the semimembranosus, and the semitendinosus, are supplied by the deep femoral artery, the caudal gluteal artery, and the caudal femoral arteries. And then they are innervated by the sciatic nerve. The cranial muscles of the crus, like the cranial tibial muscle, the fibularis longus muscle, the long digital extensor muscle, and the lateral digital extensor muscle, and the fibularis brevis muscle, are supplied by the cranial tibial artery, and they're innervated by the common fibular nerve. Now, the caudal muscles of the crus, these are the popliteus, which is a rotator, the gastrocnemius, and the superficial digital flexor and deep digital flexors are supplied by the popliteal artery and the distal caudal femoral artery, and then are innervated by the tibial nerve. Okay, and then there's autonomous cutaneous zones. The portion in the medial around, how do I see it? What is that even? LCF and CCF. What is that? Okay. The tibial nerve is the sensory innervation for the plantar aspect of the pes, which is the hind paw. The saphenous, or the femoral nerve, innervates the medial aspect of the crus, so that's like the shin and the calf region. The fibular nerve innervates the cranial and dorsal aspect of the crus and the pes, which again are the calf, shin region and the hind paw region, respectively. Cranial portion, so the top portion, kind of, the part that's facing cranially toward their head. Okay, and then there's the sciatic nerve that innervates the lateral and the caudal crus and tarsus. Again, caudal is toward the tail, lateral is away from the midline of the body. And that is the crus and tarsus again. And finally, the lateral and caudal cutaneous femoral nerves, or the lumbosacral plexus, innervate the lateral and caudal hip and thigh. So, kind of like below the gluteal muscles, somewhat. And just further up the body, if that makes sense. Much more proximal to the body. And then there's a bunch of lymphatic drainage. Lots of different nodes in the body, lots of different areas. Bones, I kind of... Oh. Yeah, bones. Okay. Good to know. And I think, hold on, what am I missing? That was Friday, I believe. No, that was Monday. Oh yeah, then the 18th was a long lab. Okay. That's it for the 15th of September. Catching up, but slowly. Thanks for watching, and I'm about to start another one after I rest my head for a bit. Thanks for watching.